morning, everyone. We'll promise to do a very quick tap dance on behalf of ourselves and our other collaborators, including Dr. Nick Van Zyl, who's at the back of the room today. We just thought it was probably worth having a discussion about the fact that our research team actually has the makings of a complex system approach, and that's not an accident. We actually did want to go quite broadly when we thought about who needed to be involved in this particular project, and I think we've accomplished that. So, and yep. Mirella, you might like to talk about the RMIT contribution as well as WDHS.
Yeah, well, I was very excited when Nick and Dorothy contacted me to be involved in this project, and as a lecturer and researcher, I'm also a health psychologist. I was really excited about the data and doing some data analysis, and a bit more on that later.
Yeah, that's kind of the whole story. So, there we go.
Okay, so cognitive decline was actually mentioned a little bit earlier this morning. And so what we know is that in the region and across Australia, we've got an ageing population, and even more so in regional and rural Australia as well. And the research literature tells us that people that go in for surgery, up to 60% can have cognitive decline, so cognitive impairment following surgery. And the thing is, we don't know why this is happening. It doesn't seem to be related to type of surgery or length of surgery or anything like that. And as a psychologist, I was thinking perhaps it's related to the trauma or the stress related to having surgery. So that's one of the things that we wanted to investigate.
Indeed. And so I guess we were also thinking about why is this a problem, and as an inveterate social science researcher myself, that was probably more my interest in this. Why is this happening? Why is this a problem? It's a problem because it can increase the use of community-based services, it can increase the use of health services, and that's clearly an issue, but also it can lead to a loss of independence for the individuals concerned. So we've got a couple of complex situations that are sitting behind this particular question. But I guess the thing that we needed to know first, and I think this is one of the realities of working in a smaller rural health service, is that we're really at the coalface of that interaction between academics and people with quite a broad interest in specific questions, and a need for our clinical investigators to see some real clear evidence base behind that. And those of us who were in the workshop yesterday would know that that's got to be your starting point. So we actually needed to reinforce that data that Mirella has discussed at the local level. We thought we needed to do that, and we wanted to know if this is actually a problem for us, then as Mirella said, what's going on behind that? What are the factors that are causing this? Now, I guess the reason that we thought this was particularly important is that we sit in a small rural community which has an increasingly aging population. In other words, the younger people tend to leave and the older people tend to stay. So the cohort who's going to be admitted to hospital over the next period of time in Hamilton is likely to become older and older, a larger part of the total patient population and an older cohort as opposed to now. So if cognitive impairment is a potential disrupting influence for the current models of service delivery and the lived experience of the person, what are we going to do about that? We need to know why, and we need to know what we can do about it. Clearly a job for systems thinking. On we go. I think this one's Mirella.
Okay, so we had a number of research questions and aims for our study. One of the things that we wanted to find out was how big was the problem? How many people were coming in for surgery, and how many of these inpatients had cognitive decline? So that's one of the things we wanted to know. We also wanted to know, of those people, did they get reassessed in terms of their cognitive decline? Were they readmitted for surgery? If we could get any information about their prognosis, also what was their survival rate, because the literature also says that if people do have cognitive decline after surgery, they're much more likely to die within a year or so. So they were some of the questions that we were interested in. And so there's some data from Sean McDermott, who's going to be a future collaborator at Ballarat Health Services. And and he's much more of an expert in the cognitive area than I am. And he says that his findings show that at least 35% of those over 65 have levels of cognitive decline. So we were expecting that sort of figure from our study.
So, Mirella has talked a little bit about what we did. I can talk a little bit more about that because I had the joy of actually flicking through the records and trying to patch together this very complex story of what it looks like in a hospital record when somebody comes to hospital and is screened for having a cognitive impairment. So we decided to do this as a retrospective study. We went back to the year 2010 and we took that whole year. We had we had a cohort of people who'd had surgery and had at least 2 nights admission and a general anaesthetic. That cohort was chosen because anaesthetic has traditionally been seen as one of the key factors in that drop, increase in cognitive impairment during hospitalisation. I shouldn't talk about it as a drop. So I went through 219 records from 2010 and we followed up any who showed evidence of cognitive impairment in their records. So we were going to do that by checking the abbreviated mental test scores that every person over 65 is supposed to have applied to them when they enter hospital. So, as usually happens with data.
So unfortunately, what we found is that the process wasn't being followed. So every patient was supposed to be screened for cognitive decline. If they showed evidence of cognitive decline, then they were supposed to be re-screened. However, that didn't happen. So of the people that did, about 60% of those that were sampled, and so we had a sample size of 220, and about 60% were screened, so instead of 100%. So from that, we can't make any really conclusive statements about the levels of cognitive decline in our sample.
Indeed. So what we did find, as isn't surprising, we usually set out with some brand new research. We found what we had not expected to find. We did find failures of process and failures of product. So what we discovered is that the AMT not only is not being regularly applied as it should be, but we probably found a couple of the human factors behind that. The AMT is actually not a particularly good predictive score, a predictive tool to use, and the scores were perhaps not meaning anything. I would say that meant that a lot of the nursing cohort who were meant to be applying these tests were kind of looking and going, this is kind of a waste of time. And we can make a judgment about whether or not this person has a cognitive impairment. So just very briefly, because we are on a time warning, we found about 30%, as Mirella said, 35% where the AMT was not administered. And there were some significant quality issues with some of those other recorded scores as well. So you get to know handwriting as you're going through files. I know that there's at least one person who just obviously makes an assessment, says this person's more than 7. So if you get less than 6, you have to go on to that MMSC or other form of a cognitive impairment testing that is a finer grade than the AMT, but that wasn't happening. So, and then I started reading the clinical notes and realised that we had some really significant problems that were showing up in clinical notes that were belying the scores that we were getting. So, where is the cognitive decline? It's well hidden in the system at this stage. What do we do next?
What do we do next? So the next, we're doing maybe you could talk a little bit about the pilot study, the little study that's going on?
Yeah, I'd be happy to do that. So, yes, Mirella's already said that we have already sort of co-opted Dr. Sean McDermott from Ballarat Health Services, who is looking at the, Ballarat Health Services had the original cognitive impairment identifier project way back when, which will probably be familiar to quite a few of you, and now have the Dementia Care in Hospitals project, so this is important for us as an alliance. We have reviewed the screening tool. Now, we also thought that we better check and see if the process is still failing, so we're in the midst of going back and doing a 1-month retrospective study from July of this year, looking at all medical and surgical admissions, because we also started to realise that one of the factors that was influencing the score was the fact that these were surgical rather than medical admissions. So then the really important work comes. We need to start to identify why the process is failing, and this is where we will go hardcore into systems thinking. And we'll talk to you about that maybe next year.
Okay, so what we're hoping to do, following on from these two small pilot studies, is to fix the process, to find out why the process is not working, and to see what we can do to fix the process. And because we're talking about human behaviour, one of the things that I've mentioned to Dorothy and to Nick is we need to find out what are the barriers to the people who need to administer these tests so the tests get done. And we also need to look at using the best tools available to screen for cognitive decline as well.
So we've finished right on time, I think. That's it.